So our next speaker is Dr. Lakkireddy, and he's going to take another tough one, and that is to try to explain the purpose of the left atrial appendage.
Thank you, Ted. It's actually a very difficult job to follow Sam's talk. I mean, because he does such a wonderful job, picks up the most difficult topics and pieces it apart and serves it on a platter, right? It's wonderful. So I tried to not live up to it, but at least make an attempt. So I was asked to talk about the physiologic contributions of the left atrial appendage on systemic homeostasis. So we all tell people that these appendages are useless, these are vestigial structures, and they don't really have a whole lot to do with physiology of the human body. But we do believe that there is more than it being just a simple vestigial organ, and I'll try to go over some of the things here. Can I have my slide deck, please? I think it's the wrong, yeah, that's it. So these are my disclosures. So when you look at this left atrial appendage, imagine the left atrium as a chamber that has this little out pouching. I mean, there is a mini chamber attached to a chamber. And what is its role in the cardiac cycle, and how do the volumetric changes impact, and how do we really assess these things? So anybody, most of you that have done a little bit of echo here, you understand that during the Doppler phase of it, we all try to put the Doppler on the left atrial appendage opening and then try to collect a little bit of those flow changes across the left atrium. So if you track my mouse, the very first wave that you see is the positive E wave, which is basically a reflection of the early diastolic emptying. That means as the left ventricle relaxes and the mitral valve opens, it creates that negative suction effect on the rest of the atrium, as if there is a force that is trying to pull the blood towards the left ventricle, and that passively empties out the left atrium. So this is one of the passive emptying of the left atrium that creates this E wave. And then you have the passive filling that follows that, the downward deflection there. And then you have the active contraction of the atrium that happens, that contributes to the atrial wave. And so when people talk about the left atrial stunning, what they talk about is this loss of this A wave, this loss of active atrial contractility, whether it is after a direct current cardioversion or a pharmacologic cardioversion, or termination of atrial tachycardia or atrial fibrillation during the radiofrequency ablation, can result in this transient stunning, which means the active contractility of the left atrial appendage is lost. And this is clearly reflected in this beautiful slide that shows the diminished A waves and how it slowly recovers over a period of 60 minutes. And it's believed that the electrical cardioversion probably has the most impact and causes the most stunning of the left atrial appendage than other forms of cardioversion, like the pharmacologic as well as catheter-related ablation. And you have several other waves that can follow this big A wave that reflects the in and out changes of blood flow across the left atrial appendage. So that's a little bit to do about the contractility of the left atrial function. So is that a reservoir? So when the human body needs increased cardiac output, does this left atrial appendage really blow up big, balloon out, and accommodate for the extra fluid changes? That means, say if the body receives a ton of salt and your overall fluid volume increases, will this left atrial appendage accommodate these additional fluid changes and thereby prevent dramatic changes in various neurohormonal modulators in the body that could potentially lead to fluid retention, pulmonary edema, and those type of things? So some of the smaller studies that have been done show that the left atrial appendage is more distensible than the left atrium. As it is clearly shown in Sam's presentation, these little pouches, I think, act as nice little reservoirs where the blood can fill in and helps us to accommodate for those pressure changes. So after left atrial appendectomy, usually the compliance decreases and the ratio of the reservoir to conduit function obviously decreases during that early ventricular filling. So does the appendage have any secretory function? I mean, does it release any hormones? It sure does. The atrial natriuretic peptide, which are these granules that you find in the cardiocytes of the left atrial appendage, seem to be one of the major functions of the left atrial appendage. The right seems to be more active than the left, and perhaps that's probably the reason why when you take away this left atrial appendage over a period of time, the body still compensates, and maybe it's the right atrial appendage that takes over the function of the left one way or the other. It seems that the ANP secretions is more closely related to the appendageal wall distension than the elevator pressures in the atrium or within the appendage. So this is a good example of these granulated cardiocytes that have the secretory ANP granules in it. To sort of simplify the atrial natriuretic peptide physiology within the human body, there are several sources, including atria, ventricles, adrenals, kidneys, of which the atria seems to be the most common source of natriuretic peptides. And you have all these stressors, which is anytime you have a change in the volume or the systemic sodium levels, and there is an atrial stretch due to exercise, myocardial ischemia, all these things can act as triggers that would neurohormonally modulate the atria, and especially the atrial appendages, to secrete more atrial natriuretic peptide that have a consequential effect on systemic homeostasis. I mean, it's amazing how much this appendage really does without us realizing it. So some very elegant early studies that have been done as early as 1985, 88, actually a lot of surgeons looked at these things, looking at what happens to your ANP levels when you ligate all these appendages. And what they have noticed is when you give them a fluid challenge, the ANP release actually dramatically decreased in patients who had an appendectomy. Similarly, their sodium excretion actually went down. If you look at the urine output, there is a decreased urine output. So for all those who do the layered ligations or have experienced surgical ligations, you might have noticed this. And a lot of people do have a significant decrease in urine output. Some people actually develop mild amounts of renal dysfunction that is very transient, but if you really pay close attention, you will actually see that. There doesn't seem to be a major change in the central venous pressures. Again, this graph clearly shows that in people who had appendectomy, their ANP levels significantly decreased over a period of time, and obviously their mean blood pressures are also slightly lower, and this is just a reflection of the sequential change in the ANP levels. And their response to exercise, the release of ANP levels with exercise seems to be attenuated when their appendage is ligated. So atrial natriuretic peptide plays a very important role in sodium excretion. It inhibits the renin-angiotensin-aldosterone system. It increases the systemic and tissue glycerol levels, so it plays a major role on lipid metabolism. And it decreases insulin resistance and increases insulin levels. Are we adversely affecting all of these functions by decreasing atrial natriuretic peptide? And how long does this effect last? And is this effect permanent? Or are there parts of the heart that actually compensate for it, and as a result of which the homeostasis comes back to its baseline? So this is a good example of how the atrial natriuretic peptides affects the urine outputs and the fractional sodium excretion through the urine. And with increased ANF infusions in people where the appendage has been ligated, you find a beautiful response of increased urine output and increased sodium excretion and so forth. So this goes to tell us that the appendages are an important source of ANP, and removing these structures can decrease the response of ANP to all the stress factors, and which in turn can impact the natriuretic and diuretic function. Its role on the lipids. So there is data to show that it helps in the stimulation of the membrane receptors of the fat cells that results in increased cyclic GMP levels and the dependent phosphorylation, and that in turn causes lipolysis. So keeps things under check. And it also helps increase fat oxidation and increase levels of non-esterified fatty acids. So there is also a lot of upcoming research in this area that clearly goes to say that ANP plays a pretty significant role in lipolysis, lipid metabolism, and we don't really know if the exclusion of this left atrial appendage in the long term has what kind of effects on lipid metabolism. That's an area of great interest for all of us, and we are actually looking at it. And if you go to the glucose metabolism, the typical markers of the glucose levels or the glucose resistance, which is indicated by the HOMA index, seem to be affected or influenced by the atrial natriuretic peptide. So if you look at the ANP infusions, you would see that the systemic blood glucose levels go down and the insulin levels get better. In fact, the sensitivity of the insulin in the system actually improves as well. So how does it impact the renin-angiotensin system? It seems to inhibit the actions of aldosterone. It counteracts the renin-angiotensin system by increasing the urine and sodium excretion. So there is a profound impact on the neurohormonal system. So to really summarize this, you have a complex interplay of the central nervous system with the autonomic nervous system, which in turn has, very intricate, detailed effects on the three major metabolic aspects of the human homeostasis, which is glucose metabolism, lipid metabolism, the sodium renin-angiotensin system. These are the three big aspects of the human functioning, and ANP seems to have a profound effect on that. So to that extent, we have started out a registry at our institution actively looking at the impact of left atrial appendage exclusion on atrial physiology and systemic homeostasis, what we call the LAA exposis, that specifically looks at all the things that we have talked about a few minutes ago. So does ligation have the same impact as occlusion or clipping? That's something that we don't really know, because with ligation and clipping, you're actually removing the atrial tissue and you're completely eliminating it. Whereas with an occlusion, you may not be eliminating or you may not be killing the appendageal tissue. There may be a mechanical obstruction to it, and the vascular supply in and out of this appendage may still be intact, unless in some cases there are really cases where they've really shown fibrosis of this appendage and the complete electrical silence of these appendages. So that's something that we really need to figure out. So that's sort of some of the questions I had in my mind about what the physiological aspects of the left atrial appendage could be. I think the field is wide open, and the onus is on us to figure out what we're going to do with it. This is our second version of the Appendage Symposium. And again, I would like to share the Global Atrial Fibrillation Alliance, which is a true partnership. So for all of those that are here that are interested in the science of atrial fibrillation, please join GAFA and help us improve the level of understanding of this arrhythmia to the people around us. And you're welcome to be part of the World Atrial Fibrillation Awareness Day on September 14th. With that, I wrap it up. Thank you very much.